All right, welcome back to MetroHealth Emergency Ultrasound YouTube channel. Today is February 29th. You got it. It's leap year. It's an extra day in 2024, which means we're coming back at you with an extra little bit of ultrasound information here. If you've been following along with us, you'll have recently seen our exciting news that we just got to the 5,000 subscriber mark. We're pretty excited about the ability that we have now to bring ultrasound education to more and more people, not just in our hospital, but around the world with this YouTube channel. If you've also been following us, you've noticed that the last couple of weeks we haven't really posted much in the way of videos. And that's largely due just because February's been a busy month for us. I've got a couple boys who've had birthdays this month, and so I've been out of the office doing mostly just clinical shifts over the last few weeks, just now trying to catch back up into some of the academic things that we've been doing and the administrative things that we're doing here with ultrasound. So we're going to get ourselves back on track as we head into the rest of the spring. There'll be a few weeks here and there that we're going to miss due to spring break and AIUM and things like that. But we got a lot of interesting topics planned and things that are lined up for us coming up later this spring. So definitely keep an eye on the channel. If you haven't yet, feel free to hit that subscribe button. If you like the content that you're seeing here, definitely hit the share button, send it to a friend, hit that notification bell so that you can be notified every time a new video comes out. But in this context of leap year and an extra day, I wanted to provide a little extra morsel of information for you guys. I've been talking to a few people around the hospital lately about IVC ultrasound. There's been some questions about the utility of IVC ultrasound and what we can use that for and what does it mean. And so I thought it'd be interesting to talk just ever so briefly about the use of IVC ultrasound and kind of some of the nuances that I've learned over the years about IVC ultrasound. So there's basically 3 points that I'd like to bring to you guys today. Number one is IVC is best understood if we view it as a reflection of the right atrial pressure. There's been a lot of data that's tried to use it to push it one way or the other versus volume responsiveness. And I think if we back up and think about anatomically what it's connected to and physiologically what it does, it basically is a capacitance system that is directly connected to the right atrium. And so whatever the pressure is going on in the right atrium is reflected down into at least the proximal IVC, and it gives us a little window that we can use to assess the physiology of the right atrium, right? And so with that being said, there's multiple things that will affect the right atrial pressure. You know, we oftentimes get ourselves stuck on this whole idea of volume, right? It's a preload problem, right? Or, you know, is it high preload or low preload? But we also have to remember that the right atrial and right ventricular function will definitely affect the right atrial pressure. So if you have RV failure, you're going to back up into your right atrium, you're going to have a larger IVC, as well as the integrity of the valves, right? And so if you have a tricuspid regurg or something to that effect, you're going to put more volume in the right atrium. You're going to get more pressure. That's going to be reflected into your IVC. And finally, the status of the pericardium, right? If you have a large pericardial effusion that's causing some obstruction of forward flow, i.e. pericardial tamponade, that itself is going to back up fluid into the right atrium and the IVC, and so you're going to have a larger IVC. So I think as we think about the IVC and what does a large IVC mean versus what does a small IVC mean, if we view it in the context of right atrial pressure and then understand the differential diagnosis that's created in that framework, that will help us then to identify what's going on and really develop this understanding that you can never understand the IVC or interpret the IVC divorced from the heart that it's attached to. So you always have to then go look at what's your LV function, what's your RV function, what's your pericardial function, what's your valvular function. It's going to really give you a better understanding of what's going on with that IVC. So that's number one. Number two, IVC measurement has limitations. You know, one of the things that we commonly do, just because it's easy, is you put an M-mode caliper right through that IVC, just distal to the hepatic vessels, and then throw the M-mode in gear and watch the IVC go from wide into narrow and wide to narrow as the patient takes a breath, or we may tell them to take a big sniff. And that we do that because it's convenient, right? And then we get one picture, we can take a couple measurements, we can then calculate the collapsibility index or the distensibility index or whatever, you know, calculations you want to do. But we have to realize that there's limitations to that particular image. Now, it may not be an inaccurate way of doing it if you are careful, but it can be very inaccurate if you're not careful. And I say this for two reasons. Number one, when you take a breath, right, the diaphragm is going to flatten, right? That's going to have a cranial caudal translocation of that IVC throughout that respiratory cycle. So when you're fixing that M-mode caliper in one spot and having the patient breathe, you're actually measuring two different spots in its largest and its smallest diameters, right, from a cranial caudal perspective. So does this really mean a ton? Probably not, but just realize if you want to be very scientifically accurate, right, you're not measuring the exact same spot, right? And number two, when you put your ultrasound probe in the long axis on the IVC, right, you have only the view of the long axis. And so you can either narrow that IVC down based on the actual physiology of the pressure becoming less and becoming more, right? Or if you translocate your probe just a little bit lateral or a little bit medial, that can also artificially narrow it as you're now measuring a different part of the diameter, actually not the full true diameter of the IVC, right? Measuring a false diameter, right? And so you don't have that understanding when you put it in M mode of whether or not you have that lateral translocation of your transducer relative to the IVC, right? And so these are two limitations. What I usually recommend is say, okay, interpret the IVC in long axis in just 2D mode, right? And then turn it in short axis and kind of get a view in two different planes of what this IVC is doing, right? And if the ultrasound that you're taking, if the M mode measurement that you're taking is consistent with what you're seeing in long axis and short axis, accounting for all these nuances, then fine, take the IVC M mode and use your calculations off of that. But always check your work as opposed to just putting the M mode on and then just letting it run, right? Because there's these nuances. So that's point number two. Point number three is kind of the big elephant in the room as it pertains to IVC, and that is volume responsiveness or fluid status, right? And everyone wants to make the IVC answer this question: is this patient volume responsive, or are they not volume responsive? Because what we don't want to do is we don't want to flood someone who cannot tolerate extra fluids with fluids, and it's like, well, I guess they weren't volume responsive. We'd like to kind of know in advance. In the original literature that came out about the IVC, kind of suggested that there may have been some correlation, but over the years, as we kind of understood the nuances and a little bit more about the IVC, we've realized that correlation breaks down, and that if you want that definition of volume responsiveness, where are you on that Starling curve, right? Are you on the low part or on the high part? You're probably going to need to do some more physiological measurements of the heart itself, specifically LVOT VTI measurements, and see with a passive leg raise, is there going to be any change in your LVOT VTI that would suggest that they're volume responsive. So the way I like to use the IVC is not necessarily in answering the question, is this patient volume responsive? I.e., if I give them more volume, what's going to happen? Because I don't think that test is really going to be able to answer it, at least in isolation. What I like to do is use the IVC to tell me, is my patient volume tolerant, right? Because we know that the IVC is the venous side, right? It's a large capacitance vessel. And so it has some distensibility, it's some ability to absorb preload and store that there, right? And so if you come in with a patient who's hypotensive, right, who needs some form of either volume or pressure support, and you scan them and they have a very, very small IVC, I know that they have capacitance to gain more preload, right? And they're probably preload down, but I can't prove that for sure. But if I give them fluids in that situation and watch their preload, expand, then I can see kind of how they respond, right? Whereas you take the same patient who's 60 over 40 and you measure the IVC and it's just plethoric, right? That tells me that they have a very high right atrial pressure. Their preload is not low, right? And so at this present moment, they're probably not going to tolerate much more fluids because their capacitance system is definitely enlarged, right? It's at its max capacity, as it were. And so I probably need to start with them on some pressure support and then see what happens, as we get the heart working a little bit better. And so reframing the question may be a little bit more subtle, right? It may be nuanced, but it takes us from, is this patient going to respond to my fluids? I don't know. The test isn't going to tell me. To, is this patient going to tolerate my fluids decently well when I plan on giving it to them? So anyway, those are 3 points specifically about the IVC that I find to be helpful, that kind of bring a nuanced perspective to the IVC. If you want more information about cardiac ultrasound, definitely hit up the playlists about cardiac ultrasound. We have a lot of helpful information from both myself as well as Ziad Shaman, our MICU attending, and Ashish Anisha, one of our cardiology attendings, as we all try to understand kind of what's going on with the heart specifically as it pertains to ultrasound in the critical care setting and in the ED setting. So hope that's helpful. Definitely stay tuned. We got more great lectures coming out from Grand Rounds and some more shorts. We'll see you next time.